It's my pleasure to host this panel today on It Takes a Village to Drive Quality and Patient Engagement. I have three other esteemed panel members. This is going to be a little different than the last panel in that we did not prepare slides on purpose so that we can engage the audience for the majority of the discussion. I might start out with a couple of questions after everybody gives maybe a 3 to 5 minute presentation on an area of their interest under this topic, and then we will open it up to the audience for questions. To my right is John Henderson. I began working with John in February when he took over the role of CIO at Chalk Children's Hospital where I work. And he's been a wonderful partner. He came to us from Texas Children's, where he had various roles at Texas Children's. He was an associate vice president there, had responsibilities for IT operations, including business and clinical applications delivery, business intelligence and analytic and infrastructure technology for healthcare organizations. And Texas Children's is a $4 billion organization. So that was a large chunk of work that John was involved in, but we're very pleased to have him now at Chalk, and you'll all be meeting him here at various FHIMSS events. Kara Marx is next, and Kara comes to us from Sharp Healthcare in San Diego, where she is a VP of Applications. In this role, Kara is also a nurse, has been a past CIO, and has responsibility for all the clinical and business applications. Over the past year, Kara has participated in kicking off several new committees, including committees focusing on patient, consumer technologies, population health, and innovation. So we'll be looking forward to her comments as well. And the other panel member to my right is Amy Wynn Howell. Did I say that right, Wynn? Yeah, okay. And she's the Chief Medical Officer of CAPG. She currently sees all clinical programs at CAPG and supports advocacy work in Sacramento, California, and Washington, D.C. It's a professional organization consisting of 300 physician organizations in 44 states. So not just California in focus, a national focus. Those organizations are also in Puerto Rico and Washington, D.C. Dr. Nguyen contributes to national committees that provide structure for innovative care delivery model focused on payment reform and integrated patient-centric care. She's a faculty member at USC, Saul Price School of Public Policy, and continues to serve as a family physician at Playa Vista Medical Center, so currently an active clinician. So I will start out with just a couple of minutes of comment on sort of an area near and dear to my heart. A little bit about Chalk. We are just finished our Stage 7 recertification. We became a Stage 7 EMR adoption model hospital in 2015. We won the Davies Award in 2016. We are the only children's hospital in California that's certified as a Leapfrog Safe Hospital. So obviously, over the years as we've developed information technology at Chalk, the focus has been on quality and patient safety to the extreme. Even the name of our system, we're a Cerner client, but we don't call it Cerner, we call it CUBS, which stands for Connecting Users and Building Safety, which is really what it's all about. So we've been very successful on the inpatient side of the organization in improving quality and patient safety and providing for clinical care at the hospital, but things are changing. Most of the care doesn't occur in the hospital. In fact, if we look at the pediatric population of Orange County, only about 10% of that population actually makes it into the hospital. Fortunately, most kids are healthy. It's a little different than adult care, where as you get older, all adults get chronic diseases, and eventually everybody ends up in the hospital at one time or the other, pretty much. With kids, that's not the way it goes. Our goal is to keep them out of the hospital. Even kids with chronic diseases, what can we do to keep kids from getting sick enough to need our help? So a good example of that has been our focus on population health technologies, adopting the Healthy Intent platform from Cerner and being the development partner for Cerner. But also, it's not just giving people data on how they're doing, it's giving people ways to improve care through the implementation of guidelines. We were the awardees of a Center for Medicaid and Medicare Innovation Grant called TCPI, Transforming Clinical Practice Initiative. It was about an $18 million grant that we received in 2015. The goal of that grant is to roll out clinical guidelines into practices throughout Orange County and then in San Diego County with our partner, Rady Children's Hospital. And through that initiative, those guidelines are going to be used to improve the care actually delivered. Within Cerner, we were able to build those guidelines into our EMR, and they are somewhat complicated for some of the guidelines, but for gastroenteritis is easy, asthma is very difficult. But those are all now integrated into our EMR, and our ambulatory physicians are using it. So does that make a difference to start practice? Certainly did on the inpatient side, but what about the ambulatory side? What have we been able to achieve over the last couple of years? Just by implementing guidelines for providing data back with registries to patients. We talk about value. One of the things we've been able to achieve is to pretty dramatically reduce the number of kids being admitted for asthma. Cut it in half. The readmissions for asthma, cut them in half. ED visits for asthma dramatically decreased. Now, you might say from a hospital perspective, where's the value there? Because you've just cut my revenue down. Well, the other thing with CHOC is we have 153,000 capitated lives in the Medicaid or Medi-Cal in California. And so we're at full risk, capitated risk through CalOptima for those patients. So if we can eliminate an ED visit, we can have more capacity in our ED to bring in paying patients also that need ED services. If we can keep a kid out of the hospital who has a condition like asthma that shouldn't ever end up in the hospital. It's a preventable admission the vast majority of the time if you have the right care, if you're on controller medications, et cetera. So if we can eliminate the need to hospitalize patients, while our COO gets a little angina over that when we tell them we're reducing inpatient admissions, what it's actually done is allow a little more room for patients who really need to be there to be hospitalized. It's actually improved our payer mix some. It's actually improved our bottom line to keep kids who don't need to be in the hospital out of the hospital and to create capacity. So that's been kind of my focus. Our patient engagement has been, I wish I could say we've also really focused on patient engagement. We've stood up a portal, not very well adopted, not widely used. We're enhancing functionality. But we are now in the point where maybe John can talk about how we're kind of prioritizing now for the organization, improving our overall patient engagement. So do you want to
Sure, I'll take
that lead?
When you think about patient engagement, as Bill mentioned, typically you have an EHR, everyone has a portal, but it really doesn't accomplish everything. It's very singularly focused of what it can do. So one of the things we're doing at CHOC is really taking a step back to try to figure out patient engagement as a whole. Not only from the portal perspective, but how does marketing fit into that puzzle? What aspects of patient engagement can they help us drive? From a philanthropy perspective, how does that tie into it? Then you think about the social and mobility aspects of the digital patient experience. How do you connect with your patients, patient families, particularly in pediatrics? It's really about the mother and father, the parents. How do you engage with them in a way that they need to be engaged? You have to look at the different demographics, the millennial generation, Gen X. What's the right way to engage? So you want to have various mediums. So we're looking at all of those aspects of patient engagement and coming up with a strategy that can truly be enterprise and really cover the continuum of how we need to engage our patients, whether it's best way to, how do you find our facility? How do you gain access? Making that process simplified and easy. That's one of the things we hear most from our patients and our average focus groups is, how do I get there? Where do I park? How do I find the right care at the right time for my child? So our approach is really looking at all of those aspects of it to really enhance the experience. One other thing to consider, when you fly, before you take off, you get the normal safety mechanisms. If the safety mask drops down, you're supposed to put it on yourself before you help anyone next to you or your child. When you think about engagement, one of the things you also have to consider with the digital strategy is what does it mean internally? So you also have to think about the nurses, the providers, the patient access center staff. What are we going to do with them to make this process easy for them to help the patient? Because if we make it easy for the patient's family, that's a wonderful thing. If we make it so cumbersome and onerous on the folks internally, that may have a negative impact on patient satisfaction. So you have to also think about what it means internally to drive that patient engagement with your digital experience. And that's one of the things we're also looking at with our strategy.
Okay, great. Kara?
Sure. Hopefully many of you are familiar with Sharp Healthcare. We're a 7-hospital system, 2 large medical groups, and various community services, including retail, pharmacy, home care, hospice, and we have a health plan down in San Diego. Those of you who know Sharp, hopefully you're aware of what's called the Sharp experience. And the Sharp experience is something that we live by. It's part of our DNA. And the Sharp experience encompasses everything we do. So it includes physician experience, staff experience, and of course the patient experience, patient consumer. So we have always been extremely patient-focused, to the point that all of our acute care facilities do have Plaintree designation, and I don't know those of you who are familiar with Plaintree, but Plaintree is a commitment and a philosophy of a family and patient-centered approach. So in everything we do, we've always been looking at that. Of course, speaking from an IT perspective and a clinical perspective, we try to weave then the technology with our patient philosophy and connecting and engaging them in all aspects of the entire continuum, which is sometimes where the challenge gets presented, because it's very typical that even though you're a health system, the way that we care for patients can still be fragmented. Don't think just because y'all have Sharp in front of each of your buildings that the technology is seamless. Sometimes you have a population of patients who are capitated lives, and you're doing wellness, and they're engaging with the health system in a totally different way than when they present for an acute illness and when they're discharged and how you can follow up with them. So we've been focusing a lot on how to improve that engagement of technology to become more seamless across all these different areas. Patient consumer is the new lingo that we try to use internally to make sure that we are including those who have not yet engaged with the health system, but might be part of our health plan, to those who are receiving acute care for a very episodic event, and then those who either check with us once a year for a wellness physical or for a ongoing chronic disease management. We do have a lot of capitated lives. One of our large medical groups, Sharp Reese Steely, has over 70% capitated lives. So you can imagine from that alone, the focus on patient engagement and looking at them as a whole in and out of healthcare is very important because of just the business and the way that we're reimbursed for that population. Additionally, we are a member of the new ACO for Medicare, so the next gen ACO, and looking at a population of patients that way too. And when you're working primarily with seniors, it's a little bit of a different approach. However, don't underestimate their involvement with technology. We, like CHOC, have really leveraged the portal. So we have a very mature portal. We originally had a self-developed portal that was successful for many years, but as meaningful use increased their requirements, we revisited managing a self-developed product, and we went with an industry-available product, which we use Follow My Health in conjunction with a couple different EMRs that we have running in the health system. We drive a lot of engagement through the portal, and we push our vendor partner to continue to develop that. We do our video visits for primary care through there. We allow self-scheduling. We do a lot of education. But we also leverage a lot of other remote technology to touch our patients, and I can get into that more detail as we go on related to population health. But all types of technology in any way possible, app development, et cetera, I'm happy to discuss it more. Wherever we can find a way to reach out and engage the patients and provide further value, we've dabbled in it so far. So happy to share more as we continue the discussion.
Great, look forward to it. Amy?
Hi, good morning, everyone. So I apologize for my hacking up here. I have this horrible bronchospasm because my boss has been working me too hard. So I've been traveling nonstop, literally since August, almost every week. So how many of you have heard of CAPG? Great. So we are a national organization, so not just California Association of Physician Groups. We used to be that. We dropped the California, and now we're national. We are in 45 states, over 300 physician groups strong, Puerto Rico and Washington, D.C. So our groups, what differentiates our organization, our association, from others that you may be familiar with, is that every single member has some sort of risk-based coordinated care to their model. So not only is it a delivery reform model, it's also aligned with some payment reform in a risk-based contracting. So whether it's shared risk, upside only, upside downside, ACO, bundles, or full global capitation, that is our shtick, and we're sticking to it. So, so unlike the others, I am not a CIO. I love technology, and I think I was interested in being a panelist, and also we also work with HIMSS very closely, in that I'm seeing how technology is seeping in very slowly and very cautiously into the delivery aspect, the delivery model within our organization and within our groups. However, it's driving the way that physicians and the care teams deliver their care. And I don't think that's the way it should be. I think it should be used as a tool, and so that the physicians and their care teams should drive the way and have a voice in how this tool is to be used. So whether you talk about EMR, you talk about telehealth, to even like blockchain technology, I think it's very important to have a physician and a clinician at the table when you're designing these processes, because they are at the front lines. They understand how the delivery is going to be implemented. They understand their patients and what their patients want. And so to not have them be a part of the design process and the implementation phase, I think would not be very futile. So I think also one thing that we have at CAPG that no other organization has is we call our CAPG Standards of Excellence. And with that, it is a survey, an annual survey that all of our members can complete, and they pull data from their organizations to understand how well they're tracking on that movement from volume to value. How well are they performing pop health analytics? How well are they delivering care coordination? How well are they collecting data on social determinants of health? And then we also ask them about their payment model and how well they're being reimbursed, and how well their physicians downstream, because most of our groups are capitated, how well are the physicians and the clinicians being reimbursed downstream, because I think that's also very important. So with that, I'll hand it back. Well,
I'm going to put you a little bit on the spot, because I'm going to ask you, as a practicing primary care physician, what do your patients want? If you could give them any technology, any service that they could access through technology, what are they asking for? What do they really want us to provide?
So with respect to technology, I think just generally stepping back, what patients want is to get in touch to see their doctor when they can, when they need to, when they want to, when they can. So it's that access. So when you put in the technology layer, you have to look at the individual customer, the individual patient, and you have to look at the line of business with that organization. So if you take Medicare Advantage, your patients, are most likely more elderly. So are they going to check into that patient portal? Are they going to access that? Or are they going to go on Facebook? A lot of them have iPads. A lot of them use Facebook because they connect with their grandchildren that way, with their children. So they use Skype. So they're more likely to connect on a telehealth perspective or checking in that perspective with a monitor because that's what they're used to. Or if you're in a commercial market and you have a big contract with an employer and you've got millennials involved, well, they want it now and they want it right now, right? They don't watch TV. Everything is on their mobile device, not even computers these days, and they just want to be able to dial in, open their app, and get their birth control pills or get their sore throat or their UTI resolved right away so that they continue to do whatever they want to do. So it's really important to understand the customer, the individual customer, and then also to understand your client, who, yes, is also your customer, but also where are their pain points in their revenue stream and their reimbursement scheme.
Okay. One of the things that I've noted is a lot of our clinicians are very anxious about how opening up to patients electronically is going to sort of impact their lives, the messages, the refill or the renewal requests, seeing data before they can really look at the data and can interpret it for them, and whether they'll understand what the lab result or radiology result or something really means. So there's a lot of clinician anxiety of opening, particularly to a millennial that wants everything and wants it now. So we've had quite a battle with our clinicians to try to find the balance of what their their fears. It's interesting though, if you actually look at it, there are very few requests for personal communications that actually get to the doc. It's usually handled by the nurses. It's usually things like renewal of meds, scheduling appointments, or other things like that never gets to the doctor. But the doctor has a great deal of anxiety over it.
They do, and doctors feel like, well, if I gave them my mobile phone or if I allow them to have this access, they'll overuse it or they'll abuse it, and patients, and they don't. They really do not. They are very respectful, and especially if you've had that relationship with them for years. And as a family doc, I've got generations that I've taken care of, and they don't abuse it whatsoever. But there is that anxiety, and then there's also that level of burden that docs aren't getting paid to do these things, aren't getting paid to open up messages. But I think that payment reimbursement needs to change, and it is changing at certain health systems, especially in Southern California.
Yeah. Kara, in terms of leveraging the kind of technology, the portal technology, visits, other things that you're doing, how successful has that been? What's the utilization rates of that kind of technologies that you've extended out, or any other issue related to the mobile technology?
And that is a metric we follow quite regularly. We're really excited. We just hit 200,000 patients in our SRS medical group's patient portal, and the utilization is significant. We have made the portal accomplish a lot of things. So we are doing full open notes, and there was a lot of resistance.
Oh yeah,
It was
big time.
We went slow, but it is being embraced. We're also doing a clinical communication exchange where the patient can text the provider, and that's again through our portal. And there was concern that'll be overwhelming for refill requests, but it really ended up being managed quite well. I think in today's era of technology and the millennials and the need for transparency, we really have to just start to jump in with this. We recently also just had the clinicians post their health grade scores up on our webpage, so now the patients, when they're searching for a visit, and they're hesitant, it's not what they're used to, but that transparency connection with the patient, it really creates more of a partnership. So we've had wide adoption, but we're not naive. We don't believe that every single person's going to go to the portal. I mean, I think that's silly. So what we've decided to do is we're building out a strategy just on our webpage with creating a single sign-on portal. And we want to match some of the functionality that we have on the portal just with our website. So our website, which was recently relaunched with some newer web technology, is mobile friendly. So we get a double, you've got the same look and feel, so consistency. And now we're really dealing with that convergence of the digital marketing side. So for those of you who might work with your marketing departments who often own the digital strategy of the consumer and kind of community facing, then you have to get the clinicians at the table. So marketing's pushing one way because they have a goal of growth and development and market share, and then the clinicians are like, well, wait a minute, I need to use that web page to accomplish some population health technology. So we're trying to go broad and cover Apple, Android, website, portals, reach as many people as possible.
Now, John, we're going to want to do all that too. How are we going to be able to justify the staff that would be required, the development resources, the funding that's going to be required? How are we going to prove value from all these patient engagement initiatives that our organization is prioritizing?
Well, I think the presentation before talked a lot about that. It really ties to it. You really have to articulate the value. If you think about end-to-end, patients want access, information, transparency. I call it the front door. To access and consume any services that we provide, they want information and an easy way to do that. So I think the value is there. Marketing, to Kara's point, they want to grow. So what they're trying to accomplish, there's going to be some return on investment there. When it comes to just access and activation use of the portal, more information, better engagement with the patients, patient families, that's going to also potentially drive additional use of our services and consuming of the different services we offer. So another potential value. But really, it's the experience and providing the right care, the right place at the right time. You tell that whole story, the value proposition is there, but also the experience and what we're trying to provide. Better quality care, lower cost, and improve patient experience. That digital transformation aspect of it really helps you drive to that. It has to be core strategy. So I think the business case is there. You just have to do a little bit of the work to present it.
So I think we are the only thing between you and lunch, which is in about 25 minutes. So why don't I open it up to a couple questions for the floor and see what you guys are interested in on this topic. Nobody doing e-health, or Bill,
No,
you
we
had
have
a
one.
question over there. Do we have?
We have a question over there.
Thanks a lot for sharing your experiences. My question is actually pretty brief and simple, which is, how do you gather the voice of the consumer? What are some best practices? How have you brought them into the development process or looked at your portal, your website, and those kind of things?
So for Sharp Healthcare, we each of our entities have active, it's part of our Plaintree designation that we have patient focus groups. So we do have a list of people we bring in on a regular basis, and they get fed and maybe they get a gift card. And we change the topics to get the feedback to ensure that we have the pulse of that. We also recently invested in a tool. It's a little bit like a crowdsourcing tool, web-based, and the membership consists of employees, our volunteers, or anyone could sign up for it, but also some of our patient population. And we send questions out that way as well to get feedback, so leveraging technology. And then, traditional survey feedback as well. So as many different ways as possible, we involve the patient, consumer, family, community.
I think we do. I think we do a little bit of that as well. You get the patient satisfaction surveys. Our marketing group really looks to understand what's being said in social media, what kind of experiences people are talking about CHOC. But we also have a patient family advocacy group that we also get direct feedback on things that are going well, things they'd like to see us do differently, so we can tap into that to better understand what their needs are.
Yeah, so our CAPG members do all of the above. And I think that's one of the main reasons why I'm still in practice is I just ask my patients. That's the best pulse. That's the best barometer of what do they need. Are they getting what they need through technology, through their physician organization, through their PCP? Is basically to ask them. And I work in an urgent care setting, so I'm lucky to see across generations and try to adapt to all those needs.
Yeah, I had one while we're waiting for the next question. I have one related to e-visits, e-visits into the home. It's a new technology that we're implementing, but there's a lot of pushback by the physicians because there's no reimbursement for e-visits. Now, maybe at Reese Staley, if they have 70% cap, they can construct within their own group reimbursement for, that's less. You can do an e-visit. That means the patient doesn't have to come in. You don't have to provide the staffing for it. You can accomplish a lot of what you can in an acute visit or a planned visit just electronically. How have either the CAPG practices or Kara in Sharp, how have people handled that issue of physician reimbursement?
Well, you're right. We don't worry about the reimbursement that much because right now our e-visits are follow-up visits. So we've not done new patient visits and we're not doing kind of that e-urgent care scenario at this time, although it is being looked at by our other medical group, our IPA model. Sharp Community Medical Group is currently looking at using our telemedicine after hours for the practices that don't have that coverage. Again, the IPA model, it makes more sense. We have found, though, which was interesting, and I thought the video would be embraced more, we started with telephone visits. And the telephone visits took off surprisingly well. And then we introduced video, and it's being utilized, but not at the same rate as the telephone visits, which was a little disappointing to me. But nonetheless, we're hoping that it will catch up. And some of it is clinicians they're saying use the phone follow-up. They're not selling the video follow-up. But we do see a lot. There's so much more you can see from a video. I mean, just in the patient follow-up and the assessment and dialogue and mannerisms, we would like to push the video more. We also are trying to branch out with telemedicine and patient engagement to use education. So how can we do group classes for, we have a lot of high-risk pregnancy patients who don't come in for their follow-up visits. How can we have group access to forums to let patients engage in that fashion? Because sometimes they are intimidated one-on-one, but they're more willing to join something when it's a collaborative effort. So,
yeah, Kara, you bring up a good point in terms of the physicians leading it. So we have one organization in Bakersfield. It's a PCMH, patient-centered medical home, and it's driven, the e-visits are driven, the video piece when it was introduced was driven by the physician. So it was driven by the leadership and encouraging the patients, oh, you should log on, you should really use this, it's great. And then it totally took off. And now they're using it in group visits as well. So again, I would not underestimate and undermine the physician leadership aspect of involving any technology at your organization. With respect to e-visits, one of our groups in New York, Mount Sinai, is actually doing it because they are capitated, and they're doing it for their homebound patients. And they are seeing a huge recoup on ROI because of the HCC and the Medicare Advantage STARS aspects of it. So the coding aspects and just being able to code that and getting the STARS, closing that gap for those patients.
Yeah, thanks. John, did you have any experience down at Texas with the video visits, e-visit type of technology?
We did. We didn't really worry about the reimbursement either. So we really took a couple different approaches. Out in the community, particularly on the women's services side of our business, we did a lot of video conferencing, video visits for OB-GYNs back into our maternal fetal medicine specialists. That proved to be extremely effective, identifying high-risk pregnancies and different things that you could intervene on. I think the other thing we were doing was focused on post-surgical follow-ups. That's something that we found to be extremely beneficial, better for the provider, but also more easier for the patient, so they have to come back in. Texas Medical Center in Houston is a very small place, around 70,000 employees in a very small confined space. Not a lot of parking. So trying to navigate that was a big challenge. So keeping them out of the medical center when they didn't have to was a big satisfier.
Yeah. And one thing, particularly with, I think do we have a microphone or we have one back there? One thing with global payments for surgical procedures, the follow-up visits are part of the surgical fee, so you don't have to worry about individual reimbursement. So surgeons are much more likely to jump at the technology. Yes?
Yeah, this is Ken Lewan from Sharp. I'd like to understand a little bit more about your work with Cerner and the Healthy Intent platform at Chuck, how that experience is going, what you're looking to do as far as engaging patients, managing populations. Could you talk a little bit more about that?
Sure. Briefly, it's kind of a whole topic into itself. But for example, on the example that I gave for asthma, in addition to implementing guidelines, we have a registry that comes off our Pop Health platform. And in that platform are Cerner's data, but also data from a variety of other sources, other practices, in particular our IPA, our claims data from our IPA that handles those 153,000 patients. And so someone can log on and view how they're doing following those guidelines. For example, the two things we tend to look at is asthma action plan. Have they initiated an asthma action plan? When we first rolled that out to one of our practices, they had a compliance of about 16%. Of course, the thought was everybody got an asthma action plan, but it turns out it was 16%. And we got them up within about 6-8 months, we got them up to over 40%. Asthma control test that the MA administers, so both the doctor and then the MA, we were able to show an improvement from a similar kind of abysmal 17-18% up to about 60% of the patients where they actually have an asthma control test administered to them. Those practices using those tools for a year-over-year ED visits, we reduced by 18%, which estimated to save nearly $1 million. And that's through the combination of guidelines, but also giving people feedback on how well they're following the guidelines. So I think that's one of the keys to population health, is having an analytic platform that can give data back, and in this case, it's given back to the point of care while you're seeing the patient, trying to avoid missed opportunities to improve care. So we could, afterwards, I'd be happy to chat with you more about it, but that's a big thing. That's a big part of what we're doing right now, is trying to get that utilized across the care continuum. Let's see, we had a question. We got another one over there? Okay, we have another one here.
So you mentioned it before, and I run into a lot of pushback with patient engagement. It's not my job to tell somebody to come in. Can you talk about, the aspects of, you mentioned HCC coding. Where are the revenue benefits of being able to identify the appropriate patients within a cohort and driving those patients back into the practice and being able to generate revenue within that existing patient base?
There's a huge ROI on that. So with respect to patient engagement, if you look at just taking Medicare Advantage, patient engagement is about more than half of all of the measures. So getting care quickly, getting access to care, getting your appointments quickly, getting the customer service that you want, and then all the medication adherence stuff. And so most of these measures are not just weighted 1 point, they're 1.5 or 3 triple weighted. So if you can master that patient engagement, and which Sharp really has, you can really get that whole ROI just on your Medicare Stars measures in that respect. And then of course with HCC coding, that's a little different, but you can kind of cushion that in your process for quality improvement as you streamline your workflows for your practice and your group. Does that make sense?
And, you know, at Sharp, we have, at the Reese Daily Medical Group, they have been doing some really great things with population health and remote monitoring. So the ROI on that has been very easy for us to capture. And that's technology that I think many of us have heard about. If it's Propeller Health and tracking with the inhaler, or it's CardioCom and looking at the patient's weight and doing basic vital signs at home. We also are using just texting for diabetics patients and at the right point in time. Those are vendors out on the marketplace that we've partnered with. What we've recently started doing with our innovation group is how can we identify a problem and then attack it with a solution that we create ourselves. So recently, looking at the elderly population, this was to address a little bit of scheduling challenges and medication adherence. And the costs associated with repeat visits is we had a physician champion who had an idea for an app, which I'm surprised no one has asked about apps because it's a little fun buzz thing. But you get asked for a million apps, like, could we build an app for this? We invested in this one app with this one physician. It's built off of the Apple CareKit platform, and it's for cataract surgery. So at first you might think, cataract surgery, how much, is their cost? Well, interestingly enough, we have such a backlog of patients wanting cataract surgery, and then we had a lot of unintended cancellations. So we said, how can we get the app to help manage a better show-up rate for the surgeries and lack of cancellations? So we built that into the app as reminders and prep and the importance of planning. Medication adherence. Into the app we built, a lot of follow-up is if you're not taking your drops correctly on follow-ups post-surgery, you can have complications. So we said, how can we make the app remind them and teach them how to take the drops correctly? The right angle, how many. Sometimes with post-cataract surgery, you can have 2 to 3 different drops and varying frequency. And you're dealing with an elderly population, typically with surgery. And when are they getting their discharge instructions? When they're coming out from anesthesia. So there is a lot of opportunity to say mobile technology can give me timers, show videos on how to take an eye drop. They can work off, the Apple Watch. We built it in so it would leverage that as well. And I think there's a whole area. It's just a slippery slope to not get too excited about the cool factor and build something that's just fun. Make sure there's an ROI. The pilot so far, because it's relatively new with this cataract app, we've seen amazing results. We've had 0 cancellations, which is just phenomenal. And just impressive. Alone, they said fund more, do more other types of surgery. Yeah. And the other thing is a medication adherence. So when the patient takes the drop, then they document in the app that they took it. So we can track that at-home administration. And studies have shown that there only is about a 35% adherence rate with eye drop adherence. And we found that we were closer because we could match the prescribing dosage to what they said they took it, and it's up to like 60 to 70%. So to get that type from a national benchmark of 36 and have that type of improvement, there's something there. But you do have to make sure you measure the value, and it's not just all cool factor. But one good scenario we've seen so far, and hope to capitalize on that further.
Great example. Let's see. We have a question waiting up in front.
Thank you. Nick Semple with PA Consulting. So thanks for coming to the kind of remote monitoring. One of the questions I had was, to what extent are you looking at, from a patient interface to voice technology? So we're doing some interesting things and looking with some of our customers around how to use things like Amazon Echo to both use some of the adherence technologies, but also, drive some of the kind of remote monitoring pieces and reminders around appointments and all of those kind of things. Are you doing some of that? And if so, could you share that?
Okay.
Well, we don't have anything scheduled for deployment with those technologies, but those are things we definitely have to look at. To Kara's point, it seems obvious to start to explore those technologies, but you have to be really clear about what you're trying to accomplish so you can actually see if you're going to get some value. And will it be valuable for the patient family? But really, everything that we've talked about, there's this underlying platform, this asset of information that really drives everything. And so that's really what we're really focused on, is how do we leverage all the data in this rich asset that we have to drive patient experience? Because you also find that that'll really help you figure out what existing patients you have where you can do more for them and maybe grow some revenue as well, but also identifying new opportunities within your market.
Yeah. The other thing that you have to kind of control a bit is there's a lot of provider enthusiasm out there for this app or that app, this new widget. And a lot of practices have joined our foundation as part of our pediatric system of care that we've been developing at CHOC. And one of the practices was using an app for strabismus. So in other words, squint or strabismus, where kids' eyes aren't aligned properly. And initially it was kind of presented like, oh, we've got to renew this app. Wait a minute, what app is this? Who's been using it? Didn't know anything about it. And it turns out now that the entire primary care group now is using this app, and it's very effective in screening patients for strabismus. We have a new pediatric ophthalmologist who only has limited capacity to, and there's a few other people that do pediatric ophthalmology, but if we sent every kid to them who had a question of some muscle imbalance in their eyes, you'd probably just totally overwhelm them. But if we can really focus on those kids using an app and the photographic capabilities of that app to screen patients for strabismus, one, you're going to catch more of the patients and get early intervention so later on they don't have problems with things like amblyopia or other issues, but two, you're going to more appropriately use your resources, and something like pediatric ophthalmology is a limited resource. So that was just another example.
Yeah,
of something.
I think the app marketplace is an untapped thing. Ochsner Health did a lot of really, it still created this O-Bar, which is a place where patients can get prescribed apps, and then they can get support to put an app on their phone. And that may not have been developed by the health system or not, but it's like, how can I leverage technology that's out there that may not cost anything if it's approved and been vetted by the health system? So I think that's another marketplace, but to get some clinician oversight and approval, I would support that as a vetting process.
Yeah. Question?
Hi, this is Frank Nguyen with Apple, and I am going to ask an app question. So you talked about engaging different parts of the business, whether it's marketing or physicians for ideas. Are there insights you can share on how to effectively do that to get the right apps out there and how to continually improve those? How are you guys doing that with your physicians and your marketing teams?
So it's an interesting question. So we have an innovation group at CHOC, MI3, we call it MI3. We have some of the representatives here, Dr. Anthony Chang over here to my right. Do a lot of vetting and reaching out to our provider community to really understand what opportunities exist and how do we vet those ideas through that group, and then get to IT to really understand, okay, can we take this from concept to a reality? So that's one aspect. We do some what we call strategic grants, where we do call outs to the organization. You can submit your idea, and it has to be tied to one of our strategic priorities, but you can submit that idea and it goes through a process where you may get awarded some funding to pursue that forward to see if it can become a reality. That's one of the ways in which we're doing it at CHOC.
Yeah, I would say at Sharp a similar approach. Also, when you have someone who has a passion, like we have this physician who built the cataract app, he's his own roadshow. I mean, sometimes we're like, get back to surgery, stop showing everyone the app. But he's really promoting it, and what he's doing is he's kind of saying, like, imagine this. So he'll have a room full of physicians, and he'll piggyback on a medical staff event, and he'll say, what is your discipline, and how could this apply to it? So now we're starting to think about orthopedic, so if you have the framework of the app built, which is pre and post surgery, which is where you'll get a lot of your high cost complications. What about other, and now we have like even endo, prep for GI and endo is huge. Sigmoidoscopies, who would think? Well, the cancellation rate is so high. Because who wants to go through the exam, right? You wait till the last minute, right, before prep to cancel. But that's how we capture our cancers, our colon cancers. So how can you use an app to improve? And this physician, Dr. Tommy Korn, he's just an advocate, and I think using him is spurring people to think about the possibilities. That's not by us. That's him out doing his own thing because he believes in it so much. So sometimes I think it's informal ways.
Definitely at CAPG, it's informal. We do have 2 formal committees, an IT committee and our clinical quality leadership committee. So the physicians get together, the clinicians, and they share best practices, they share insights. They, ask each other, well, what do you think about this vendor? Or what do you think about this app? Or what are you using? And that's the way that, they articulate and share their information.
Yeah. Okay, we're coming up on lunchtime. We have about 3 minutes left. Maybe I can turn to our panelists to see if you have any final comments, starting with Amy down there.
I think if you are like an Apple out there or an organization like that, and you're looking at the healthcare industry and what's the next step, what's next for America's healthcare, putting politics aside, putting our administration aside, and the agency, the CMS aside, I think the next step would be for technology, as it relates to technology, would be in the field of AI and population health management. So if you can master that and translate that in a way that will be understood by physicians, clinicians, and their entire care team, they can articulate that and push that, not push it, but empower that onto the patients for full embrace and full kind of adoption of such technology. But we really need to find a way to really manage our population better and smarter, because those who are chronically ill with multiple behavioral problems and chronic illnesses, so both behavioral health and like COPD, diabetes, hypertension, that's only going to cost our country more money. So we need to figure out a way to treat these patients in a much more efficient way, in a more caring way. But how do we know who those people are, and are we really getting to them where they need the care best? So that would be my challenge to all of you, is to find that particular AI component or technology to really push through population health management for the next generation.
Okay.
And to add on that, I couldn't agree more, but from a more tactical sense, I think and we are mostly IT people in here, I believe, there's untapped potential with your marketing departments, the digital marketing, your web services, your business development. They look at things different than we look at them, different than clinicians look at them. And that perspective gives you a wider viewpoint on how to strategize to look at the population. And we've had a group now together for a while trying to work as one, and we all come at it a different way, and we're learning, but we've come up with some really good ideas that we want marketing to think about the acute care patient, not just the market share of what health plan you're going to sign up for. And we want the doctor in the office who's following up on chronic care to remember the experience in the acute care. And so just teaming up with maybe not historically normal partners in the health system, I think it's an untapped area. So I challenge you all to go back and partner with those folks.
Yeah, John will give you the last word.
Well, I mean, I couldn't agree more. I think if you're the Apples, when it comes to app development, that's really the big future for how we improve healthcare and the untapped potential. Really taking the time to really meet with hospital physicians, administrators, to really understand what's really needed. I think if you can really tap into that sort of group to really drive your technology and how to make it easier for health systems to consume it, I think that's really, really important. I think that's really the missing thing. With health systems, we're obviously, we want to have structure around, we can't just accept any technology. Having it go through an app store, through that vetting process is important. but really looking at what do the health systems really need to deliver care and drive the effectiveness and efficiency of the care through these technologies is really important. And I think that's really a thing that's missing. I know there's always advisory groups that different vendors have on their within their warehouse, but I still think you guys are missing the mark. I think you have to actually come to these health systems and sit down and talk and understand what's really going on to help drive the improvement that we're looking for.
Okay, well, great. I want to thank our panel for excellent discussion.